Thank you, Aaron. Welcome, everybody, to what I think is going to be a really interesting and informative and thought-provoking session. We've got people representing the CNA voice, as well as those who are medical directors in post-acute care. So I think it's going to be an interesting meeting of the minds, and hopefully we can get some interesting discussion going here as well. So I'll just begin with a brief anecdote, which is that the last time I spoke at AMDA, pre-COVID, probably 3 years ago, addressing a room full of medical directors and attending physicians, I opened by asking people the following question. If you are the resident of a nursing home, would you rather have a wonderful CNA or a wonderful physician? And again, bear in mind that the audience was almost entirely comprised of physicians. You probably can guess that the answer was everybody raised their hand to the idea that they would rather have a wonderful CNA, even more than they would like to have a wonderful physician. So obviously CNAs are where the rubber meets the road in skilled nursing. The residents spend more time with the CNAs than with anyone else. CNAs can really set the tone for a nursing home, and certainly individual CNAs can set the tone for a unit. So I'm glad that we have an offering today that will highlight their voices and also give them an opportunity to speak directly to people who are in positions of medical direction. So I'll introduce the speakers today. First and foremost will be Laurie Porter. She's co-founder and CEO of NAHCA, the CNA Association. She began her career in long-term care in 1980 and was a CNA for 7 years, followed by 7 years as a nursing home administrator, and then regional operations director of 10 skilled nursing facilities before co-founding NAHCA. So she certainly got experience that's very broad ranging. Sherry Perry has been a CNA for 36 years, 26 years at her current facility in Tennessee, which serves 198 residents. She's the current board chair of NAHCA and has presented on many webinars and in-person events on important issues facing CNAs. Sheena Bumpus has been a CNA for 18 years and been a professional CNA in the same facility throughout her entire career. So congratulations, Sheena. She works full-time on the dementia unit at her nursing home, and she's the vice chair of NAHCA's board of directors. Chris Leach has been a CNA for 20 years. She's been employed for 12 years in a skilled nursing center in Iowa. She served on many committees in Iowa and is the newest member of the NAHCA Board of Directors. Congratulations, Chris. So at the other end of the spectrum, Dr. Timothy Holahan is a board-certified geriatrician and palliative care physician with the University of Rochester, up here in good old upstate New York. He's a certified medical director and serves as the medical director of 3 facilities in Rochester. He also currently serves as the vice chair of the AMDA Ethics Committee and is a member of the AMDA Public Policy Committee. Dr. Leslie Hebert is a certified medical director and divides her time between clinical practice, medical directorship, and research. She's the medical director of Orchard Park Healthcare Center in Greenwood Village, Colorado. She's also the chair of the Colorado Dementia Partnership and is on the national board of AMDA. She's also an advisor to the Colorado governor's COVID-19 residential strike team. Finally, Dr. Swati Gower is a geriatrics, hospice, and palliative medicine physician. She's a medical director in post-acute care facilities in the state of Georgia, and she's chair of the Infection Advisory Committee with AMDA and a member of the COVID task force. So we have a bunch of great panelists. We're going to start off with Laurie Porter, and then we'll move forward into discussion and comments, and hopefully we'll have time for Q&A. So Laurie, I'll turn things over to you.
Thank you so much. Really appreciate that, and good evening to everyone. I thank you for taking the time to attend this candid look at how CNAs and medical directors can work more closely together. We certainly feel these two disciplines share a common goal and inherit the health and welfare of our patients collectively. Throughout this pandemic, both AMDA and NACA have found we share so many of the same values, and how through working together we can make needed improvements by first knowing one another, and secondly, coming together to explore ways to improve care culture in post-acute and long-term care. We really value AMDA and Healing Together providing an audience for CNAs this evening. It is pretty historic. I mean, it is revolutionary for us to be together tonight. I'm joined by three of the best career CNAs in the nation. There's much to learn from CNAs, but also much for us to learn about medical directors. CNAs have been called heroes during this pandemic, but it's more than a word. Heroism is ingrained in how they act, work, think, and how they feel every day. They don't have jobs. They're called workers often, direct care workers. That sounds like a job. What CNAs have, the good CNAs, have relationships. During this hell called COVID-19, they didn't lose patients or residents, they lost loved ones. They often are more like family to the residents than the residents' own families are to them. And they know these people better than just about anyone else could ever know them. They took the losses of the residents hard, and despite all the trials, challenges, and risks, they were honored to hold their hands at the very end when no one else could. We often assume everyone knows who CNAs are. Sometimes we as CNAs make that mistake by assuming people know who we are. But very few people really understand what drives a CNA, especially a professional career CNA, which is what we all aspire to get to. We have in large part destroyed this critical position on a care team. CNAs have been marginalized throughout the years, time and time again, long before a pandemic. They've been marginalized by supervisors and the management that they report to. This event tonight may be the best thing to come out of the pandemic. A new model, if you will, where CNAs and medical directors work together. Sherry, Chris, and Sheena will share with you some thoughts and ideas that you can start to see the real power of your influence as medical directors, and vice versa, their real power as CNAs. Workforce is all we've heard about lately. I believe what we need in post-acute and long-term care is a care force, not a workforce, a care force, uniting teams around quality. So without further ado, let's get to the three ladies that are here tonight to help bridge that gap, to help you understand who they are and how the two of you together can make an added difference in this profession. I'm going to turn it over without further ado to Miss Sherry Perry, NACA's board chair and career CNA. Sherry, you're muted, dear.
And Sherry, if you can hear me, if you could tilt your camera down so we see all of you. More, that's better. Perfect. Thank you. Yes.
Right. So thank you for being with us tonight and providing this platform to share our thoughts. As someone who has been an active full-time CNA for 36 years, it never really occurred to me who our medical director was and what their role is exactly. So when Laurie invited me to be part of this panel, I began to really think about me and my fellow CNA's relationship with the medical director and how things could be made better if our medical director really knew who we are. So the average CNA doesn't feel as though they can approach a medical director. CNAs must follow the chain of command, and that ends with the administrator and does not include the medical director. It also occurred to me that most CNAs don't even know what a medical director is. They just know the doctor's here. So I'd like to share a strategy I feel medical directors could do starting tomorrow. First, lead a transformation in the culture of the care team. You're not the employer, but you are the respected professional whose influence on our leadership can make the difference. Strongly encourage CNAs be included in the care plan meetings. Even when CNAs are included, there is no defined role for them to serve. Work with DONs to help define a role for CNAs to be engaged in the care plan meetings. Identify certain pieces of information the CNA is to bring to the table. Request when making rounds, a CNA familiar with the unit make rounds with you and the nurse. The CNA can reposition the resident as needed for physical assessment. The CNA's presence is reassuring to the resident as they are a resident's advocate. We know the residents' norms. We spend nearly as much time of our time with them as their families. So we really pick up when something's off. We just don't always feel like the nurses listen to us. Request to the administration that this becomes routine policy and make certain it is communicated to the nurse who often tries to marginalize us. Thank you.
Thank you very much, Sherry. Laurie, who's next?
Sheena's up next. Sheena Bumpus from Oklahoma. Welcome, Sheena.
Hello. To tag along to what Sherry said, I wanted to say I'm honored to be here tonight too. I'm excited. CNAs have never really had an opportunity like this. Like y'all said, I've been a CNA. Well, I said y'all, so y'all know I'm from Oklahoma. I've been a CNA for a long time, and so I'm excited to be here. I never would have thought CNAs would be leading something like this, speaking to a bunch of doctors. So thank you for this opportunity. I have the privilege of being from a small town in Oklahoma. And so we don't have many doctors. We have a small hospital. So our medical director is my personal doctor. So I have the pleasure of being friends with him outside of work. So I have a professional relationship with him at work. And I guess knowing him like that, I've never really thought about my fellow CNAs not having a relationship with him like that. So when I talk to him at work, you know, if I see something, I can just, you know, hey, this is going on or this is going on, and it gets addressed. And there's many of us that work like that. Well, the new hires, they can't, you know, just say something like that. And I've never just sat down and talked about it. So when I was getting ready last night, I got to thinking about it, and we do need to come up with strategies or plans so we can change this. And since I do work with dementia residents, you know, when the doctors go around, they can't really say what's going on. So this is something that needs to be addressed. So I come up with a plan, you know, like CNAs do, and I will be sharing that with him, and I'm going to share it with y'all. I think one of the things is medical directors need to build a professional relationship with CNAs. One of the things is when he walks into a building, whether he knows that CNA or not, stop and say hi, stop and act like you know them. You know, one of them walks by, they were supposed to wear a name badge, of course. Some of us don't always have one on. I'm guilty of it too. You know, hello, how's your day? You know, if you see them doing something, it feels good when, you know, especially the doctors in the house, if, you know, you're doing a good job or something, you know, make them feel good about themselves. You know, anytime anyone with authority or, you know, tells you you're doing something, even if it's not at work, you feel good about what you're doing. Well, you bring a doctor around, I mean, that's just going to make you want to do better the next day or whenever, especially when you're a new CNA. I mean, I remember when I was a new CNA, first time I met a doctor, I felt great about it when he told me I was doing a great job. So, and especially these last, 20 months, I guess, we're not getting a lot of recognition from families because they're not in the house. So a doctor coming around and, you know, making us feel good and telling us we're doing good, that's a big deal right now. Another thing is when the doctor's around and he shows the CNAs respect, that tends to have the other leaders in the facility follow in their steps, and then they start showing respect. So they don't have to be, you know, verbal about it. Sometimes it's just their demeanor when they're around, you know, just walk up and stand. I've seen them just walk up and stand next to the CNAs, and then everyone else just kind of, you know, goes over and stand next to them. So if we make it a point to just bring CNAs around and bring them to the table, then everyone else does it too. Another one is help CNAs not only through recognition, through education. Take them on rounds, invite them on seminars, include us in the care plans. I've been in care plans with family members, DONs, administrators, and when family members speak to everyone in there, the main two people they talk to is the medical director and the CNAs. That's who they want to hear from. And those are, in my opinion, the two most important people that family members want to hear from. Another thing that I think would be huge is if the medical directors, I'm just going to call them town hall meetings, is if they would have town hall meetings with the CNAs. Once a month, twice a month, however often they wanted to do it. At these town hall meetings, we could have, I would call them, maybe that's where we could have the continued education for the CNAs. We could cover dementia care. Right now it would be huge to cover infection control. That's one of the things state's going to be really looking at. So if we heard it from a doctor, I think it would mean a lot more than hearing it from DON or nurses. Another thing is everyone's really speaking about the vaccine. I know my facility has a very high vaccine rate, and I think one of the reasons we have it is because our medical director did come to the facility and he explained it. And at least in my opinion, I wasn't too excited about getting it until I did hear about it from the medical director. And I don't know, it was just something about hearing it straight from a doctor about it. So if we could have a meeting with, and I'm talking about just the CNAs, you know, step in, not anybody else, just CNAs and the medical director. I think that would make a huge impact on the CNAs. It would boost morale. It would show that the medical director actually has respect for the CNAs. So that would cover the continued education for them. It would maybe just ask them, you know, hey, what would y'all be interested in finding out? Because a lot of times we have questions that we don't feel comfortable asking our DON, you know. It's like, hey, y'all are supposed to know this about infection control, but I don't know how to do this, and I don't really want to ask you because I'm already supposed to know. but I'll ask once you're out of the room and I'll ask the medical director. So that would cover a lot of bases. So I think these strategies, they may work, hopefully. So I don't know, maybe we can implement them and try it. Thank you.
Thank you so much, Sheena. There's a lot of great ideas there. Absolutely. Let's turn now to Chris Leach, or Christina, if that's how you prefer.
Or mom at work.
Welcome.
So thank you. This is a great opportunity to be heard and to make a difference. Thank you for having me. I appreciate it. Pretty exciting. Like Sherry and Sheena, I didn't understand until Laurie invited me to join the panel. I never had considered about like the working relationship between the CNAs and the medical director. It has been a good lesson for me. Realize that the medical directors don't understand who a CNA is at heart. So I had a few ideas that I had thought about, and we had talked with people at work about today and everything, and they were really excited about it as well. So CNA development.
Christina, Chris, sorry. Could I just ask everyone, if you're not talking, to mute yourself so we lose some of the background noise? Thank you. Sorry, Chris.
Oh, you're fine. The medical directors are the most respected member of our care team. We all respect their decisions and what they come up with, and we all want to follow their plan. So the message matters to us. Adding to that town hall concept with the CNAs, we thought maybe if you took one of the resident cases and talked through it with the CNAs, asking them about what the difficulties are with that or what the challenges they're having with that resident, listening to the CNAs. For example, if you ask a nurse if a resident is being continent, and they'll tell you that they're continent, but if you had asked the CNA, you might have found out that that resident's continent, but they have to go to the bathroom every 30 minutes to make sure that they are. So then it seems kind of a small thing, but it could mean that there's a medical condition going on, or that it'll be helpful for in the future for that resident if we came up with a plan. And then we came up with doing some onboarding for new CNAs, maybe to do like a role as professionalisms and work through technology and stuff. We thought maybe about doing a film as an introduction of the medical director to the new staff coming on board, and then sharing their vision with us of what they're looking to do, and to set the tone for the residents on how they want the residents to be respected and treated, and kind of just introduce and give us a good idea of where we're at. And so we know the face when they come in the building, we know that's who the medical director is, and we'll be more likely to say hi and that type of thing. So that's what I come up with. So thank you.
Thank you so much, Chris. There have been a lot of great suggestions already. I think this has already been super useful, if you ask me. So just a comment before I turn things over to our medical directors. So as a psychologist in long-term care, historically, I've done a lot of behavior management plans where somebody either with dementia with behaviors or a psychiatric issue is evidencing inappropriate behavior. And as a psychologist, I kind of become the team leader for a behavior management plan, which really involves simply identifying the behavior that we want to change, and then coming up with a strategy for responding to the unwanted behavior when it does occur, so that everybody who comes in contact with the resident, if that behavior is manifested, will respond in a consistent way that's designed to have the behavior go away. I can't tell you how many times, and I always include the CNAs in these meetings. I can't tell you how many times, I come in and I start pontificating and brainstorming about, different thoughts I've had. And then a CNA says, well, why don't you just do this? because I've been doing that for years and it works every time. And then another CNA will say, oh, that's a great idea. I've never thought about that. Why don't we all do what Molly's doing? Because Molly seems to have it. And 3 times out of 4, if you get all the CNAs doing what that one CNA came up with, lo and behold, the behavior goes away. So I think, taking that approach, taking the wisdom and the experience that CNAs tend to have because they're on the front lines, and bringing that, up the chain so that it doesn't stop with me, but it goes through the unit managers, directors of nursing, attendings, NPs, and finally medical directors. I think we're onto something in terms of the value of the experience, knowledge, wisdom that CNAs really bring to the table, and which I think can be transformative. So thanks everybody for all of these great ideas. Now we'll go to the other side of the continuum. We'll start hearing from our medical directors. And Dr. Holahan, would it be okay if we started with you?
Sure. Yeah. I'll be honest. I am enlightened by what you all said. I mean, that was fantastic. I mean, talk about some great ideas, and just to be honest, I took a full page of notes. You can't read it because my handwriting is horrible, but I am taking it all down there you go. And really gonna put this to work. And I think it's important to call that out. And I'm sure, my 2 colleagues will have specific things they want to say as well. But there's one particular thing that I've been trying to do, and I think the pandemic really shed light on this, is culture change, right? How do we change the workplace culture in all of our facilities? Some need a little bit, maybe some need a lot. It just depends on where you work. And after going through some bad outbreaks, if you wanted to call a benefit to it, was some of the conversations I had with some of the CNAs that work in the buildings, and getting insights into their day-to-day experience, which I think I was missing that perspective before, and it's been extremely valuable. One of the things that I think that was said that I loved was individual meetings between CNAs and medical directors. I think I will be honest, I downplayed the value of that. Hearing you all say that, I think it truly could be a culture change and see it trickle down. The effect that we have in the building, it can't be understated. And when we talk to you one-on-one, the administrator sees that, the DON sees that. Like, that is important. Like, telling them, I'm going to meet with a CNA on each unit today, and we're going to talk. It's going to be part of my weekly routine. We're going to chat. And I think it includes them so much more in the culture of the building. I love that idea. I thought it was just fantastic. And I guess the only other thing that I'll say in hearing you all talk, and Laurie touched on this as well, is, we're hearing a lot about burnout these days. And we talk a lot about burnout of nurses, physicians, other medical providers, physical therapists. I am not hearing enough about burnout for CNAs, and they are probably the most at risk, and for the reasons we're talking about right now and all that was said. And I think as medical directors, we can gain more insight and help in that way by having these one-on-one conversations. So thank you. I mean, I think that really the only thing I'm doing is reiterating what you all said. I mean, you're the ones with the ideas, and it's just important for us to realize that and learn from it. So I applaud that, and I thank you. So that's all I got.
Thank you so much, Dr. Holahan. I'm having like a random thought. It's a little bit of a non sequitur, but thinking about the world of organizational psychology, you hear the phrase "the Toyota way." Does anyone know what the Toyota way means?
No.
Dr. Gower, do you want to take a stab at it?
Well, there is a lot of good in Toyota ways, but it's essentially every part of the team, to my understanding, every part of the team is important, and everyone so it's basically how Toyotas are made. And when someone identifies something, the whole production stops
Exactly.
because everyone's observation is important.
Right. Thank you so much. So yeah, you explained it better than I could. I think of it as anyone on the assembly line at Toyota can stop the entire line at any time. So just the guy who puts the rivets in the trunk, if he pushes that red button, he sees something is happening that is not optimal. He can push the red button and everything will stop. So it just reminds me that, you know, Toyota has figured out a way to hear the voice of every single person in the facility. And we would do well to think about that as we think about the way we utilize or fail to utilize the value of CNAs. So Dr. Gower, for nodding and smiling at me and being willing to explain the Toyota way, I'll give you the floor next.
Sure, thank you. I appreciate it. I think, you know, Laurie knows that we were just talking before we started, you know, between the six of us or so. And every time you guys come and we sit in the same forum, there is so much that we carry back home, as evidenced by this and Leslie's notes and Tim's notes. And I hope everyone is making notes. I think this information is so valuable. I think, Laurie, you told us the last time, I don't know when, round with a CNA. And I did that. and it is incredibly powerful for me. And I would actually say that, Tim, I agree with you. Before COVID happened, I know COVID did a lot to us and a lot of negative to us. But I think before COVID happened, my role as medical director and the information that I was getting about CNAs, and this may sound hurtful, is literally what they didn't do right. And I am somewhat ashamed, but I think I'm on a better path. Then COVID happened. And all the families went away. And we saw the CNAs doing their work, plus the work of the families, and expanding their role. And I'm sure I'm not the only one in my nursing home. We were short-staffed, and we got more and more short-staffed. And the CNAs took on more and more and more. But during the COVID time, I got to know Miss Caroline, who, you know, is a CNA, who this particular patient responds to, who takes time out of her whole assignment and takes this patient out so that she can maintain her function. And interestingly enough, I was talking to her son today and explaining to him, who has not been in the facility. We opened the facilities today and told him by name who has been helping his mother, 90-year-old mother, to maintain the function till he comes back. So it has literally opened our eyes. I mean, I'm speaking for myself. I think Tim shared with you all as well. And I am getting, and you know, it is so transformational for me. And going back to what Richard said, culture of the care team. And I think what Sherry was talking about, you know, that culture of the care team. If I hear one more time the whole chain of commands thing, I think I will go bonkers, because as a physician who really cares for the patient, it is incredibly important for me to have any member of the care team come to me if there is something, that Toyota way, to basically come and alert me if they are seeing something. And I think that there is nobody but a CNA who can tell, what is really going on with the patient. And I'm going to take just one moment to give you an example of a person to tell you how important it is. So there's this patient that I have who had a parathyroid surgery, who got the surgery, came back, and I was walking down the hall, and I think Sheena, you may be the one who said, stop and say hello. And I stopped, and there's the lunchroom where I sometimes stick my head in, and everybody's, hey, Dr. Gar. And one of the CNAs said, Dr. Gar, he seems nervous. His hands are tingling. He complained, and I have not ever seen him like that. And she's the only one who alerted me on this patient. I went and saw the patient, ordered some labs. He had hypocalcemia that was life-threatening, transferred him to the hospital, and that CNA, just by mentioning in a lunchroom, saved this man's life. That's how incredibly important your observations are. I don't need a stop and watch. I just need for you to come and tell me. And I think, that is where your suggestions of having that culture of openness is so important. Sherry, you said that. And Sheena, you said, just go into the lunchroom, hang out, it was so incredibly important. And I think, Chris, thank you for that suggestion. I am going to go back to my organization, and I know I don't like to be taped, but I think I'm going to try to do that, because here is the thing. I really keep thinking, I have such incredible people working. I want them as a part of the team for a long time. I can tell you, I'm having such a huge degree of FOMO right now, because I don't know how many years you guys have been CNAs in the same organization. I'm like, I'm so jealous, but that's all I have to say. And thank you for your suggestion. And Sheena, I also say y'all. I don't know if I said that or not, but I'm from Georgia.
Thank you so much, Dr. Gar. So we'll turn things over to Dr. Eber. Welcome.
Thank you very much. I just want to reiterate what lots of people have said. First of all, your ideas are amazing. I've written them all down too. I'm bringing them forward. I love the idea of, Chris, introducing myself to new CNAs and letting them see who I am. I love going to nursing stations and hanging out. And I think that this is an opportunity, as everyone kind of has alluded to, that COVID has given us an opportunity to break down these silos and these barriers and kind of form relationships with each other and honor each other. So some of the things that I'm hoping on the medical director side to bring to the table is to give CNAs a voice, to give them opportunity, to give them credit, because there is excellence happening on the floor. And I do think that calling it out, I was also going to share a story of my own. I have a patient who has dementia, but he still walks with his walker, and he's really pretty proficient about walking. And he was walking just normally, and I saw him. I always wave to him, and he's one of my very favorites. And the CNA came up to me, and she's like, no, come here. I want to show you his wrist. It was all black and blue, and it was a little bit swollen. He had fallen, but he didn't tell anybody. And she was the only one who noticed that he wasn't in pain. He wasn't walking differently, but she had noticed it that morning. I was there that morning, and she wanted to show it to me. We did an x-ray. We got him help. We treated him. I don't know if I would have ever found that. It was remarkable. And the one thing I wanted to do was thank her and tell everyone how, gosh, this has really changed this gentleman's care. What if we had not found that? What if she was nervous about coming up to me and didn't feel like she was a welcome voice? I think when we model that kind of behavior and show people that we work together, that we're collaborative, and that we honor and respect each other, then I think that so many doors open. Not only is it better care for the patient, but everybody feels better about what they're doing and how they're important in the care of the patients. And so I think it's a wonderful opportunity. I love the town hall idea. I'm totally going to do that. And I like the fact that it's CNAs only. I love that idea too. I worry when I go to nursing stations to give information about COVID and I say, do you have any questions? And I worry, is everybody feeling comfortable to raise their hand? I'm sure that's not true. So this will be another way to thread the needle. So thank you. And I just really want to acknowledge the excellence and expertise that CNAs bring to the table. One of the other things that I'm going to try moving forward, I was just talking about this with our QAPI team, we're going to have a CNA come to every single QAPI meeting and speak about what they're hearing and what they think are the gaps, where can we improve, so that in every leadership meeting, there should be a CNA telling us what we're not seeing. Anyway, so thank you for teaching us.
Thank you so much. Really interesting, great ideas. Laurie, let me give you an opportunity to respond back to what you've heard so far from our medical directors.
Thank you so much. First off, I'm enjoying the chat. It looks lively and robust in terms of ideas and thoughts. I will caution the medical directors, just as I do administrators who come out to some of our administrators and feel that they've seen the light. Don't rush back and say, I've changed. No, because it won't happen that way. So know that these ladies aren't speaking for every CNA that's currently working in nursing homes. What we really need to do is focus on the core. When we're broken in sports, we go back to the fundamentals. We go back to the core and build out from the core. These ladies are part of the cores in their facility. So if they happen to, it's easy to make a mistake as well. What if some CNA that calls in every other day that you have no idea knowing about gets a whole lot of doctor sugar? That can be opposite of what we're trying to accomplish here. So, I would just caution you with that. And then I also wanted to just throw out one other thing. It's way too big for this, but it may be something that we can engage in the future, as I'm seeing some case studies and things pop up here in the chat. Right before the pandemic, we had 1 year in which to prove this, but NACA created a CNA-driven department. One reason CNAs burn out, one reason they never know if they're making a difference is there's no measurements for CNA outcomes. When you say, get the falls down, and falls comes down, there's a big staff meeting where the administrator says, nursing got the falls down. And you assume that's everybody in nursing, but I think these ladies would say they don't see it that way. And yet they were the ones that got the falls down. So language does matter. CNA's got the falls. So without measurement, I'll give you, and it's difficult to know anything more than Bessie likes the pink dress on Tuesdays and Charlie likes his full linen changes and shaves on Fridays. And those aren't measurable outcomes. So this CNA-driven department called the Enclave Principle is new for us, and it's really Leading Age reached out to us today, national, because they think it's one of the best practice concepts they've ever heard, where CNA departments are formed and the DNA, Director of Nursing Assistants, who is a CNA, becomes a department head level that reports directly to the administrator operationally, but clinically to the DON. Nurses resent having to chase CNAs down to see if they've given their baths. And we have a hard time allowing nurses to be clinicians because they're supposed to be supervisors too. So this Enclave Principle is really a great concept in terms of we piloted in 5 Metro Detroit buildings in 2019, and they were some tough buildings. And I want to report that all 4 of the DNAs have made it through this COVID in their position, and they're on their third administrator at a minimum and fifth DON through COVID. CNAs stay. You can count on the core. So thank you much for all this time and attention, and feel free to ask any questions you may of us.
Thank you so much, Laurie. So I'm going to give us a little framework that we can use for the rest of the discussion. And I'm going to ask Dr. Leah Watson, my co-chair on the Behavioral Health Council, to respond to it first, and then we'll open things up. So here's my question. So this is a love fest, right? We all showed up tonight. We all drank the Kool-Aid. We wouldn't be here if we hadn't already valued the work of CNAs, right? So lovey-dovey, this all sounds great. Are there things that we can do to codify, if not through regulation, through dissemination of best practices, so that the thousands of medical directors who are not on the call tonight and the tens of thousands of CNAs who are not on the call tonight and the thousands of administrators who are not on the call tonight can benefit from these ideas? We're preaching to the choir tonight. What can we do to get this information in terms of best practices or regulation or something else to the rest of the skilled nursing community? So I'll ask Dr. Watson if she has any thoughts about that, and then we'll just open it up for further discussion. Leah?
Richard, you always give me the easy questions. Thanks.
Yeah.
Appreciate that.
I know you can handle that.
Lori, this is awesome. You're knocking it out of the park. Exactly what we were hoping would come to the table here tonight. And you guys, Sheena and Sherry and Chris did a great job. And it's not easy, as you mentioned, to come into a group of people that you don't know, much less people that are doctors and administrators or whatever, the people that are on this thing. So you're brave and you did a great job. So I think, you know, Laurie keeps it real. It's one of the reasons I love her so much. And I think we would be remiss to say that they're not huge problems, right? And so we need to, as people that have some leadership in the field and that are seen as advocates for the whole workforce, we need to still keep our hats on and be doing the work of getting you guys paid better and getting you better benefits and helping to advocate for a professional pathway. As Laurie just talked about, this Enclave project, you need to be seen and regarded as professionals and be paid more than fast food workers and given better benefits. So someone needed to say that tonight, and I'm happy to be the one to say it. That is not the discussion for tonight, but as people that care about CNAs, we would be crazy not to know that that's the elephant in the room of what needs to be happening. And I don't think I have easy answers to Richard's question. I mean, I think the problem is that the 30 plus people on this call tonight, it's a very huge selection bias. It's people that have drank the Kool-Aid, but it's also people like Dr. Gillespie, who's going to be leading the charge for the organization, who is going to have a lot of ears in the next year, and Dr. Eber and Dr. Gower, who have these big tentacles that go out to other communities, and we need to talk about it more. So I think keeping it in the front of our minds as we think about what I believe to be inevitable system change that's going to come out of this crisis, making sure that there's a category for CNAs when we start talking about how everything should be better, because there are a lot of conversations I'm in right now where that's not happening. And I don't want to take up all the time, but what I'll say is I get called a lot from friends, from families, from colleagues, from peers, because I've been working in this sector for a really long time. And they'll say, how should I pick a nursing home for my mom? And I say that there's one single answer, and it has to do with what the frontline direct care workforce looks like and how they function. And so get yourself into a building, find yourself a corner to watch how the CNAs take care of their patients, and the looks in their eyes when they look back and forth to each other with their patients, and see if you see any love in the building. And I send them directly to look at the CNAs, not at everybody else, because you're the ones that are there for the most time, and you're the ones that do the most work. So you should have, if not the most say, certainly a lot more say at the table than you do. So I'll
Thanks.
stop, give someone else a chance to talk.
Thank you, Dr. Watson. So I'll open it up for discussion. If anybody has an answer to my question, like what can we do to bring this to the world, please respond to that. But if you want to say something completely different, feel free. So we'll start with Dr. Eber.
Thank you. I think that, your question is a great one, Richard. I think that it would be possible that AMDA could work with NACA and we could codify some best practices, some ideas, the ideas that were all talked about on this webinar with this conversation. I think writing this down would be an enormous first step. And these are very doable ideas. These are implementable. And so I'm excited. I'm excited to try it in my facilities. And I think that spreading these ideas and writing them down and listing them as best practices, and it's co-authored by AMDA and NACA, I think that would be a wonderful first step.
Great idea. Dr. Gar?
Yeah, I would actually take this one step back or further, whichever one way you want to see it. I think, we do need to understand also that in the bigger community of long-term care, the biggest issue that we are facing right now, and that is what I'm facing in my own nursing home. And Leah, what you said is go to a nursing home. I would say go to a nursing home where you have 30, 40-year-olds, length of service, CNAs, right? That's the nursing home that is that's making sure and doing the right thing. So I think this catches the attention of the biggest problem that nursing homes are seeing right now is staff turnover. But in order to have the staff turnover, wrap your head around that, you need to be able to wrap your head around your culture. And then it kind of goes back to what Leslie said and what everyone here is talking about, to codify some of this. So you are actually going to address a real, my MBA comes out, but a business problem and a true problem of the whole industry. Thank you.
Yes, thank you. And, we know from organizational psychology circles that, if you ask people why they leave a job or why they're not leaving a job, there are two answers that you always hear. One is, I have a great boss. My immediate supervisor, I love working for him or her. Maybe I could make more down the road, but I'm not leaving Bob or Mary. And the other is, I'm part of a great team. These are my people. This is my tribe. And yeah, there might be a better financial opportunity down the road, but I'm working with a group of people that is cohesive and we get along and we work together. So those are the two things that culturally, are really no-brainers for us to start to think about. And whether that means better training for directors of nursing or unit managers or whatever the case may be, anything that we can do to improve the level of supervisoryship, if that's a word, and anything that we can do to build cohesive teams is going to be really helpful. Is there anyone who hasn't spoken yet who would like to chime in?
I had a question about a couple of things. I'm in Salt Lake City, and our brilliant Department of Health changed a regulation last year or 2 years ago to where long-term care facilities do not have to hire CNAs. So they can pull literally anybody off the street, hire them. And then the training is up to the individual facilities, which means that they are not all trained to the same level of acuity, which is obviously a problem. Then they get the training that's paid for by the facility. They spend maybe 6 months there and they hop to the place that's going to give them a better deal financially, or that's going to provide more education. And this has been a real problem for us. It's also, we have absentee medical directors. We have medical organizations that manage, let's say, a dozen facilities, medically manage a dozen facilities through APRNs and PAs. So, and now with the pandemic, it was done virtually. It was not done in person. And really and truly, the results were atrocious, absolutely atrocious, because you don't get the relationship with the CNAs whatsoever. And you don't get the relationship with the medical director. No,
Right.
even if they tell you, yes, you'll be seen by someone, and they never say who, they just say you'll be seen by a medical professional within 24 hours.
Mhm.
Well,
So could you summarize your comment or question?
well, the question would be, obviously, it's not just all about the money with CNAs, which I've heard from this group, which is wonderful. But where and what kinds of trainings or incentives would you recommend for keeping these people on their jobs, at their jobs?
Yeah. Laurie, do you have any thoughts about that?
Sherry, would you, that's what Sherry presented, you'll need to unmute yourself, on our workshop last Wednesday, that several of your peers from AMDA said every administrator in DON should be mandated to attend. Dr. Eber was on that as well. So Sherry?
Yeah, what we're seeing right now is in long-term care is, the biggest consumer of CNA employees right now. And we're seeing up to five different generations working at any given time in long-term care. And with that, there comes all different kinds of opinions and what they want out of their life career. And so a lot of things is what I put together a list of flexible benefits that meets people where they are in their life and what is important to them at that time, with the ability to go back as they change, as their situations change or they grow, that they can go back and change those for whatever, to meet their needs at that time.
Yes.
A career ladder is another big thing, because CNAs, like everybody else, they want to grow and do other things, but they want to do it within the scope of practice of the CNA profession, because that's what they want to do. That's
Right.
where they feel they make the most difference. And there's still stuff that they can do within that scope of practice and yet grow and not have to go down the proverbial nursing ladder
Right.
and keep them in that.
Yes.
So there's tons of benefits. I come up with a list of it. We have it on a PDF. I know it could be got to whoever that needs it. And there's just wonderful ideas on there, all these different benefits that, to help CNAs and any employee who is at different stages in their life. And, you have to make them want to stay in that profession. And you have to do that by honoring your older employees. The new employees have to have something to work for.
Right.
And you show them that by the older employees, your core employees.
Mm-hmm.
Thank you so much for the question.
Thank you.
And
I just
the
say one thing real quick.
Yeah.
And you made up a very good point. We are the ones here that are dedicated medical directors. Just like CNAs, nurses, there's medical directors that exist that aren't as good or ideal or perfect or different for whatever reason. And we do have to kind of address, kind of think about that. How do we spread the word to those docs? How do we spread the word to those medical directors? And your point is well taken. I saw it in the chat a while ago. I apologize. I was, I think all of us on the call are aware of that. And I think a good way to address some of that, I love this idea of posters, articles with getting real literature out to these medical directors and the legislators and everything is I think a great first step. But your concern does not go unheard. So I just want to say that.
Thank you, Dr. Holahan. Well, listen, it's 7:00. I think this was, as somebody said, kind of a historic meeting in its own small way. I also think it feels very much like a first meeting, and that we need to continue this kind of dialogue and this discussion. I think there are a lot of great ideas that could and should be put out there so that we can pollinate the post-acute space with best practices. But we're going to stop for today. I'm glad that Chris Laxton was on to hear all of this. We'll be talking to Aaron about what next steps might be. Thank you to the CNAs and the medical directors for participating, and for everybody else for tuning in. Hope you all have a wonderful Thanksgiving and a great holiday season.
Thank you.
Take care, everybody.